There you go.
All right. I'll introduce myself just for whoever's looking at this. My name's Blair Ardman. I'm one of the oncology and hematology doctors here at Lowell General Hospital, and I spoke with Mr. Butler's doctor down at the Dana-Farber Cancer Institute. I'm just double checking here. His name's David. I'm blocking his last name.
Fisher.
Yeah, David Fisher. And we talked about treatment options for you, and I asked him, should we transfer you down to Brigham and Women's Hospital? And he was telling me that, unfortunately, that he has pretty much used up all of the medications for your illness that are likely to be helpful. And that at this stage of your illness, he's not sure that the risk versus benefit ratio of any additional treatment is going to favor benefit. It's most likely to favor risk. And so at your next appointment, he was planning on having you meet with people in our palliative care department to talk about how to manage the rest of your life and how you'd like your treatment to be, understanding that there may not be any effective treatments to control your disease at this stage in your illness. And I said, right now you're on oxygen that's what we call high flow, and it's sort of difficult to go home on high flow oxygen and go down. You have to get your lungs better to get on regular levels of oxygen, because this can't be managed at home, this type of high flow. And I said, if you were in agreement, meaning you as the patient, we have a palliative care staff here that could come and begin the discussion. I know it's always better to be able to speak with the doctor who's been managing you and their team, but while you're here, if you'd like to begin the discussion, I can ask our palliative care team to come so you can see what a care plan might look like for you if they're not able to give you any treatment that's going to work anymore.
Yeah.
Is that something that's ever crossed your mind, that you might come to a point in the road where they don't have anything up their sleeve to be helpful with? Have you talked with Dr. Fisher?
We didn't discuss that. I thought there was radiation also.
I know that they had talked about transplant also, but with your lungs in the condition they are, I think it would probably be so dangerous that transplant would likely be lethal. It would not be something you could survive. So I just wanted to at least tell you what our discussion entailed, and if you think there's any way we can be helpful here to initiate the discussion. Well, we're trying to get your lungs in better shape so you can get out of here. We're not as if we're going to stop doing that, but we're not sure that that's going to happen.
Right. So
because
he's saying he's sure that it's the lymphoma.
Well, with all the treatment you've had thus far for infection and without it getting better, and with the this is sort of like a repeat performance of what I think you had down there in Boston not so long ago.
Yeah.
And yet without someone who looks like they're sick, you don't look like you have an infection, and the antibiotics haven't made it any better. We're left with the probability that all this is the cutaneous T-cell leukemia that's gotten into your lungs.
Yeah.
Yeah.
Which is untreatable.
Pretty much so.
No radiation. Okay.
Well, you can radiate lungs, but the problem is that you can only radiate a small part of the lung, because whatever you radiate, you're going to kill that part of the lung. The lung is not radiation resistant.
Yeah.
So it's almost sort of like a scorched earth treatment.
Right.
If you have a limited amount of disease here and the rest of your lungs are okay, yeah, well, we can radiate that, kill the disease, and you still have some lung function left. But if your lung function is so borderline that you require high flow oxygen, even if we were to damage only 5 or 10% of your lung by going after the malignancy, that would be enough to push you over the edge where you may not even be able to breathe on high flow oxygen, but you might need a mask or even a breathing machine.
Where is palliative care?
Oh, palliative care is here. We have ladies in the hospital that are palliative
So
care.
you're here when you receive it.
No. Okay. So, first of all, let me clarify. Palliative means a lot of different things to a lot of different people. What I'm talking about is a group of medical professionals that will sit and talk with you and say, look, how are you going to live the rest of your life, and how can we help you construct a way that may be sensible without further chemotherapy or treatment of your malignancy. We're not talking necessarily hospice, which is how to help you die comfortably. We're talking about where and how can you live, given the disability you have, if it remains permanent, until the point in your life comes that the quality of your life is so poor that you'd rather go onto a program where we only focus on your comfort and not trying to fix anything anymore. So the difference is trying to palliate your symptoms, make them better with treatment. Try to palliate your symptoms of breathing and everything without chemotherapy, antibiotics, breathing treatments, steroids, anything that might help. And then when that doesn't work and your life is to a point where the poor quality is not good enough for you to say it's worth remaining alive, then going on a care plan where we just make you comfortable. And I'm talking about the first step of acknowledging that we have no more treatment to help you for your underlying malignancy. That doesn't mean that we're not going to continue to try to improve your breathing function, try little tricks, get you off the high flow oxygen, and get you out of here. We're going to certainly continue to try to do that. So the main message is Dr. Fisher is concerned that he doesn't have any treatments that he believes that treating you with will be helpful to reverse the process and make you better.
That happened fast.
Well, it's just this damn lung thing, this lung thing that is just not getting any better. And sometimes, you come and everything, and then gets to a point where your resilience just can't sustain you as it has thus far, and you get pushed a little too far. So my recommendation, if it's acceptable to you, is just start a conversation.
Yeah.
Because you were going to see them down there in Boston, and that's what he had planned, and just to meet with them here. Well, we're trying to get the lungs better. We're not saying that's it, we're giving up. But meet with them to just, open up and start a conversation about,
What's the deal?
goals of care, what's realistic, what you're willing to accept, what you're not willing to accept. Talk about end-of-life things. Do you have a will in place? Or do you have advanced directives that say that, oh my gosh, if my heart were to stop or I were to stop breathing, do I want to be resuscitated or not?
What is it like?
Do I want to be on a breathing machine? These are questions that are important to address. just to start the conversation.
I guess I got to do that.
I would if I were you. I think it would, just more information is better than less.
Yeah.
Even if it's information that isn't pleasant to hear.
How, when they get to the point where they just make you comfortable, how does that go?
Oh.
Just give you morphine or something?
Oh, yeah. End-of-life treatment to make a patient comfortable is easy for you and the team. They can prevent suffering. That's not what we're talking about here. What I'm talking about here is just to begin the discussion about what your wishes are, where you'd like to be cared for. Just get things known in case we can't get your lungs better. But if we are to get your lungs better, it's not likely to involve more chemotherapy because that isn't working.
Right. But they don't have any other treatment.
That's what he told me. So I don't want you to think, we're getting to the point they're going to put me to sleep, and that's that. No, that's not what I'm talking about. What I'm talking about is getting not your only personal affairs in order, but your medical wishes in order. How do I wish to be treated if this happens? What do I want in case of this? Just having that done in advance, because that can take a weight off your shoulders. You don't want to be panic-driven at the last moment of your life having to make decisions like this.
Yeah.
You want to be able to have your faculties about you so you can think sensibly about what you want.
Yeah.
And I'll be here every day, and we're still going to be working on your breathing, but I just thought it'd be a wise idea to get our palliative care. I didn't want them walking in here and say, what are you here for?
Yeah.
I just wanted to tell you why I think it'd be helpful for them to be here.
Yeah.
Do I get your permission?
Sure.
All right. Doesn't mean we're not trying. It's just we have lots of folks who have cancers who get to the point where there's diminishing returns of the treatment, and in fact the treatment makes them more ill than they would have been without the treatment. And so the treatments can actually shorten their lives. All I'm talking about right now is wrapping your head around the notion that there's likely not going to be any more treatment that's effective, and now how can we manage you without treatment?
Okay.
That's what we're talking about.
Yeah.
All right. Thanks for listening.
All right, Doc.
I'll see you tomorrow.
Okay.
Okay.
All right.
All right.
Thanks.